Okay, now let's start in on chapter 46, and chapter 46 is going to go over the oral and esophageal disorders. So now we're talking about at the proximal end of the GI tract. The things I want you to know about the mouth itself can tell you a lot about your patient. Some cancers will show up early in the mucosa of the mouth, and it's an indication that there could be a problem somewhere else. TMJ is a lot of people who grind their teeth at night like this will cause a lot of pressure and inflammation on your mandibular joint right there, and patients can get a lot of pain and headaches from there. Patients with TMJ usually wear braces at night to prevent that that clenching and that constant pressure at night. So the beginning of the GI tract obviously involves the mouth. Your salivary glands, that is the first thing that actually starts producing some lubrication in the mouth. You produce about 1,200 cc's of saliva a day. And you know what? Shoot, I meant to bring in a container to show you guys of how much 1,200 cc's is. Another thing I want to remind some of you, a cc is the same thing as a milliliter. So if you see cc, it's equivalent to ml. So if you have 5 mLs, you've got 5 cc's. If you have 10 cc's, you have 10 ml. So those are the same thing. So the salivary glands up here, they start the lubrication process. They protect against harmful bacteria. You've got a lot of bacteria in your mouth, but it's what we call normal flora. It's good bacteria. It starts aiding in digestion. So the salivary glands, you got some back here near your ears. And next time, like if you're really hungry and you smell a certain food, or you sit down and you get a waft of something in your mouth, try to notice, because you'll feel these glands back here. Your salivary glands will trigger, and then you'll kind of get this rush of saliva. So anyway, so that's the beginning of the GI tract. Mouth cancers are horrific cancers. Google some images of mouth cancer. A common risk for that is tobacco chewers. People who chew, put that little snuff in between their cheek and their gum. Those patients are at high risk for oral mouth cancers, which is extremely debilitating, because if you start developing a cancer here, then they have to do fairly significant facial resections, and that has all kinds of nursing implications. So obviously we're going to try to prevent or teach the patient about the high risk of oral tobacco use. Smoking can also lead to some oral problems. So what you want to do is really promote really good oral care, and never underestimate how important it is to do oral care on your patients. You don't want them to get dry, crusty mouths. You want to keep their mouth nice and lubricated. If they're on a ventilator, especially if they have high ICPs, you want to swab it. It is imperative that you do good oral hygiene, and it's not enough just to set a toothbrush and a basin in front of the patient. Make sure that they're actually knowing how to do good oral care. You want to prevent cavities. You want to do good teaching about proper nutrition, not sucking down a bunch of candy or pop right before bed that leads to dental erosion. Let's move over to neck dissection on page 1245. Neck dissections are done for patients who have head and neck cancers, which is, it's a little outside the GI tract, but it's up in the neck, which is why we're going to talk about it. So patients that get head and neck cancers, again, the risks for that are smoking is the big one, and tobacco use. Neck dissection is a huge surgery. It's a major radical surgery, and you can see it. There's a picture on page 1246 of what that looks like, but I printed off a Google picture because I want you to see how incredibly horrific. Can you see that? I'll try to hold it still. This is a picture of somebody's neck completely wide open because they're probably removing a malignancy. And if you'll notice, see right down here, they've actually stapled the surgical gown right to this person's neck. But you can see, this is the face up here. These are the neck muscles, those big tendons, and they've exposed this entire area in the event to try to remove a malignancy. And this is what it looks like afterwards. So now your patients come back from surgery. They have this huge incision right here, and then they oftentimes have drains in, Jackson Pratt drains or some other kind of wound drain, because it's very common after surgery to have serosanguinous fluid. You don't worry about serosanguinous fluid. You do worry about bright red bleeding following surgery. But with the buildup of serosanguinous fluid, and also knowing that following any kind of surgery or trauma, within 24 to 72 hours, you're going to have the highest number or the highest degree of edema. So what do we think about in this patient who just came back from surgery and has an incision right here with these drains? It's right here. Obviously, these patients are at high risk for breathing and aspiration problems. Anytime you do surgery up in this area, now airway and breathing becomes number one problem. And then following that, after you have, after they're healed, after these drains are removed, this incision is starting to heal. A couple things. One, this is a very young person, so they probably have a pretty bad diagnosis, so they're going to have some psychosocial issues. Also, look at, this is a young female. She probably looks, what, like 30, 35 years old. Now she's going to have a huge scar right here. Okay, so that's going to be a self-image problem too. So you do need to keep in mind, but again, be very careful when you're doing these nursing interventions, because when the person who just comes back from this kind of surgery, that's not the time that we're going to tell them, you know, about how to minimize the look of the scar. In that phase, we're going to work on making sure they're breathing and their airway is patent. Once they are stabilized and getting the staples out of that incision, now we might start to talk about ways to for that scar to heal and stuff like that. Okay. Following any kind of surgery, it is important to start doing some physical therapy, because scar tissue will be minimized if you can move it quickly and keep it really limber and moving. So that's just showing some range of motion following that. Okay, disorders of the esophagus. Now I'm on page 1250. Achalasia, not super common, but what achalasia is a narrowing of the esophagus. So you have the esophagus going down into the stomach like this, and achalasia goes like this, starts kind of coming in like that. Patients will complain of feeling like their food is getting stuck. And so usually if it's not bad enough, or in the early stages, you can teach patient things like make sure they're sitting up, having lots of liquids with their foods, eating soft foods, chewing their foods really well, that kind of stuff helps. In the event that the achalasia gets so significant that food is kind of getting stuck there and really causing some problems, they can go in and do a balloon, like it's always like a balloon angioplasty. They go in, I think, yeah, page 1251 on figure 46.6, it shows you how they go in and they just insert the balloon and stretch it, kind of like they do the coronary arteries or the cerebral arteries, the carotid arteries. They can just balloon it out and stent it out. It's not super common, but you will, you'll probably see that at some point in your career. You might see it on NCLEX. Hiatal hernias, very common, especially common in people with weak abdominal muscles, people with obesity, things like that. And basically what happens with a hiatal hernia is part of the stomach comes back up through the diaphragm, because if you remember, your diaphragm is right underneath your lungs, and it is that membrane that kind of separates the thoracic organs from the abdominal organs. And sometimes in somebody who has a hiatal hernia, part of that stomach will come up through that diaphragm. if it can't be resolved with, and sometimes you'll hear it, like when you're listening to somebody's heart sounds, if you start hearing like gurgling or dripping or something, they might have a hiatal hernia, and they will complain of symptoms that are very similar to GERD, gastric esophageal reflux disease, or pain after they eat. When their stomach gets full, it hurts. There are the conservative treatments are the kind of the same things for echinacea, where, you know, sit up, small meals, liquid with your food, chewing your food really well, that kind of thing. When those start failing, then sometimes surgery is, they have to go in and do surgery to repair hiatal hernias. I already told you guys about diverticulum. That can occur anywhere along the GI tract. Mostly it's in the colon, though. Diverticulum is most often found in the colon, and as is polyps. The problem with diverticulum, and you can see it's not super common up in the esophagus, but when you have diverticulum, when food and things get trapped in there, then you worry about that getting infected, and then now you have diverticulitis. So, and if it continues to happen where the patient keeps getting recurrent infections, then sometimes they have to go in and actually surgically repair the diverticulum. Perforation, I'm going to talk about a little bit later. Foreign bodies, you'll probably talk about that in pediatrics because it's the little kids that are constantly swallowing stuff and they get stuck. It's not real common in the adult population. If it is, it's usually like a big chunk of meat that somebody didn't chew very well. Chemical burns in the esophagus. This is really important if your patient is taking doxycycline, which is an antibiotic which is very toxic on the in the GI tract. And there's several medications that if a patient takes it and they don't swallow it really well, they don't take it with a lot of water, they don't take it with a lot of food, it can actually cause a burn in the esophagus. And if it's significant enough, that can perforate the esophagus. So make absolutely sure that you are aware of what you're giving your patient and the route of administration, because if it says take with food and lots of water and sit up, make sure that you're telling your patient to do that. Okay, what I really want to focus on next is GERD, gastroesophageal reflux disease. The reason I want to focus on this is because it is so incredibly common. GERD is basically high levels of acid that are getting up into the esophagus, because the lining of your stomach is very thick and it can accommodate the acid that is in the stomach, which is very very acidic, much more so than anywhere else in the GI tract, and obviously because that's where most of the digestion of food occurs. However, if the sphincter between the esophagus and the stomach is inadequate, it doesn't seal very well, some of that acid can get back up into the esophagus and actually start eroding the esophagus. And that can lead to gastroesophageal reflux disease, and the patient will complain of what is commonly known as heartburn. Super common. So the ways to treat somebody who has GERD, there's all kinds of medications on the market. There are, and as a matter of fact, I want you to know what they are, but I'll tell you about that in a minute when I get there. Certain things like sitting up after you eat is helpful. Because what you want to do is you want to decrease pressure on that lower esophageal sphincter. You want the food down into the stomach, not up on that esophagus. Low-fat diets are good. They should not. They should avoid coffee and caffeine, like colas and that kind of stuff. Tend to make GERD worse. Tobacco makes it worse. Beer makes it worse. Interestingly enough, milk. In the olden days, we always said, oh, you know, drink lots of dairy and stuff. Well, now studies have found that milk actually contributes to GERD. It makes it a little bit worse. Peppermint and spearmint should also be avoided. For some reason, those seem to make GERD a little bit worse. any carbonated beverages should be avoided in somebody who has GERD. One myth is that they should also avoid spicy foods, but that's not the case. Spicy foods don't seem to make the esophageal reflux any worse. So, if they love spicy foods, they can still have spicy foods. That's not going to be a huge issue. They should avoid eating before bed, at least 2 hours before bed, because what happens when you eat, it stimulates the production of gastric acids, and then if you lay down, all those gastric acids can go back up into the esophagus, so you do want to avoid that. Obesity, people who have obesity are at higher risk for GERD, so your overweight patients, if you can get them on a good diet and exercise plan and lose some weight, sometimes that's all that's needed to improve GERD. Tight-fitting clothes should be avoided, especially if you've got belts or things like that right around the waist. If you relieve some of that, that'll help some of the pressure off of that stomach and that esophagus. That helps. Sitting up on, like putting your bed on blocks, or sitting it up on pillows if you can at night. If your patient's in the hospital, put them in, up at 30 degrees. And then there's a bunch of different medications on the market if those other more conservative interventions don't work. And you'll see that under management on page 1254. There's all kinds of H2 blockers, H2 receptor antagonists, proton pump inhibitors, antacids. You can put a patient on antacids, and some of them are over the counter, like Tums is just an antacid. And a lot of them now that used to be prescription are now over the counter, like Nexium and Provacid. A lot of those you can get over the counter now. Prilosec, I think, is an over the counter one now. You do need to be a little bit careful with some of the medications. Some of them, like metoclopramide, you'll know it as Reglan. Reglan increases peristalsis, which helps move food through the GI tract, so it's not just sitting in the stomach. The problem with some of those drugs, especially with Reglan, is it can cause extrapyramidal side effects. So if your patient has Parkinson's, and they are also Parkinson's disease, like we studied in the neuro unit, and they're also on other medications, that can actually, if they're on Reglan, it can actually make the side effects worse. So you need to be really careful. If somebody's on levodopa or L-dopa or Sinemet, like a lot of your Parkinson patients are, they really should avoid Reglan. So they could use some other things if they're also experiencing GERD. So you need to be careful with that. Barrett's esophagus, you do need to know, there's two things you need to know. Barrett's esophagus is basically like an erosion of the bottom of the esophagus, and it's typically caused by long-standing untreated GERD. The problem if you don't treat GERD is you have all this stomach acid up into the esophagus, and it starts eroding the esophagus because the esophagus is not designed to handle the amount of acid that the stomach can. It can handle some acid, like from the saliva and that kind of stuff. That's got some acid. It starts breaking some food down. But basically your esophagus is just a passage tube for your food to get down into your stomach. It should not have the acid up there, and it doesn't digest stuff. It shouldn't. Untreated GERD can lead to Barrett's esophagus. Barrett's esophagus can lead to esophageal cancers, which is why you need to try to prevent Barrett's esophagus from occurring. And I also meant to bring in a picture of Barrett's esophagus because I don't see one in your book. Usually they can do, like if they start suspecting that somebody has Barrett's esophagus, they can do an endoscopy and biopsy a piece of that lower esophagus and then find out if it's Barrett's esophagus, and then they're at high risk for esophageal malignancies. The other thing that's present in the stomach is a H. pylori, and that's a bacteria. Somebody who has high levels of H. pylori bacteria in their esophagus, lower esophagus, GI tract, are at higher risk for esophageal and gastric malignancies because of H. pylori bacteria that's present. So if a patient is biopsied or has an endoscopy done and it is determined that they also have H. pylori, that patient could be treated with antibiotics to get that bacteria under control, because it tends to be a little bit chronic and they want to prevent gastric malignancies from occurring. Esophageal cancers, this is not good news if your patient is diagnosed with esophageal malignancies. And typically, they will start complaining the same things where they're swallowing and it feels like their food is getting stuck. Your smokers, people who drink, African Americans are at higher risk. It usually shows up in people who are about 50 to 60 years old, much more so in men than women. Things like I said, if you have chronic GERD, untreated GERD, smoking, those are all things that increase the risk of developing esophageal cancer. Esophageal cancer, there are definite treatments for it. And again, they would do like a CT scan to find out, like, can they see a mass growing in the esophagus? Then they would go in and do an endoscopy and probably biopsy it. The biopsy then gets sent to the pathologist, and then the pathologist can determine if those are malignant cells or not, or if it's just Barrett's esophagus that hasn't converted into a malignancy yet. Once it's determined that it's a malignancy, if it is already outside of the esophagus, they might choose to radiate that area first. Radiation are beams aimed right at the cancer tumor itself in order to shrink it, and sometimes they'll do that to try to shrink the tumor before they go in and operate on the tumor, so that they can actually get more of the tumor out, because your esophagus is right here. It's right behind your heart. You've got a lot of vital organs right there. So sometimes they do that. If they have determined that that malignancy that's in the esophagus has mets to the lymph nodes, they may also try chemotherapy first. Chemotherapy is really effective if cancer has already metastasized into the lymphatic system. And then they may, in addition to all that, go in and do surgery. And depending on how big the tumor is will determine the outcome. Sometimes if it's small enough and low enough, they can just reanastomose. They'll stretch that esophagus down and reattach it to the stomach. Sometimes if they can't do that, then they have to bypass it, and that's when they'll do like a gastrostomy or something else like that. So the key here is you want to identify it at an early age. So if an African American man comes in, he's like 55 years old, tells you he's been drinking and smoking his whole life, has had GERD that, for several years that he hasn't been treating, and now he's telling you that food is getting stuck in his, when he's swallowing, that person's at pretty high risk for a malignancy, and then they would go through the whole diagnostic procedures. So what you want to do following management, management for esophageal malignancy, especially after the person has had therapy, radiation, chemo, or surgery, you want to make sure that they maintain their weight, because there's going to be a loss of appetite. So you want them on a high-calorie diet, a high-protein diet. Liquid or semi-liquid foods is good to try to get it down into the esophagus without, especially in the early post-op phase, especially if there's a reanastomosis. So you want, if food can be taken by mouth, you want to promote that. This is when you're giving them like the chocolate milkshakes and high-calorie, high-protein kinds of food. Okay, so that's what I want you to know in chapter 46. That's about it. Okay, all right. We'll see you, and then we'll come back and we'll do 47, 48.